The slide is visible, right?
Yes, sir, it is visible, sir.
Hello.
Yes, boss.
Yes, boss.
Good evening, sir.
Oh, good evening, sir.
Sir, good evening, sir.
Good evening, sir. So at 6 o'clock, I think. Mine. Okay. So 4:30, madam will start. 6 o'clock, I'll start. What time are you opening it? 4:15, right?
Yes.
Okay, boss.
Dr. Maja, you can hear us, right? I can see that you've joined.
Hello.
Yeah, okay, great.
Super.
So
I'm in. I just want to.
In about a minute, we will open the webinar room for people to join, but we will start only at 4:30. So that's about 15 minutes from now. So I'll make a quick introduction of you and then you can take over.
Yeah, yes, I want just full screen now. Yeah, I can. I am on a full screen. And I'm now talking to Pratik.
No, this is Niranjan.
Niranjan, huh?
Yeah.
Hello, Niranjan.
Yeah.
Yeah, I can see you. Yeah, host. Is my audio okay?
Yeah, it's perfect.
Yeah, so perfect. So we will wait for them 15 minutes. So
exactly, we normally give 15 minutes for people to join, and exactly at 4:30, I'll make a quick introduction and then
Yeah, thank you. Thank
So
you.
we are opening the webinar room now.
Thank you. Dear Niranjan, can I just try to share the screen just to see if everything is running okay? Wow.
Yeah, you can share. Good evening, everyone. We will start in about 15 minutes at 4:30 p.m. IST. Yeah, it's fine, Dr. Maja.
Yeah, it's fine.
Yes, yeah.
Yeah, so I can stop the sharing, and
Yeah.
when you will tell me, I will share the screen.
Sure, yeah, sure.
Yeah, so
Okay,
yeah,
thank you.
you.
Pratik boss,
Yes, sir.
we have one more vertigo session simultaneously, same time.
Yes, sir.
4:30 it is starting. 4 o'clock or 4:30?
Yes, sir.
5 o'clock. So good evening, everyone. We'll start in about 10 minutes from now, exactly at 4:30 p.m. IST. So we have just opened the webinar room a little early for people to join in. So in 10 minutes exactly, we'll start off.
Good. A very good afternoon to you all. So we'll be starting at 4:30 Indian Standard Time. That's another 7 minutes from now.
Yeah, so we'll start in about 4 minutes from now, exactly at 4:30 p.m. Indian Standard Time.
We are ready to go. We'll be starting exactly in 1 minute. Now it is 4:29, 4:30 Indian Standard Time. We'll be starting.
Okay, so let's start. Good evening, everyone, and a very warm welcome to the 5th edition of Global CME Series Lockdown Learning. We started off on April 3rd, and over the last 4 editions, we've had 11 speakers from different parts of the world presenting different topics pertaining to dizziness, vertigo, and balance disorders. And today is our 5th edition. We've had more than 2,800 delegates who have registered over these 5 sessions. So as usual, these are our social media handles. Please subscribe to our YouTube channel, Cyclops Learning Lab. There are hundreds of learning videos on that, and there are great many number of doctors who are regularly watching those videos. And follow us on Facebook, LinkedIn, and Twitter to get regular updates on what we are doing. If you have questions, ask it in the Q&A feature and not in the chat window. Any unanswered questions will be mailed to the speakers and they will directly reply to you. Please add Cyclops IDs to your contact list because we keep getting complaints that the Zoom link is not received. So it would have gone to your spam ID. So if you add Cyclops IDs to your contact list, it will prevent the mails from going into the spam ID. So today we have two great sessions, one by Dr. Maja Sritiska on updated 10-step protocol for acute vertigo, and the second one is by our own Dr. Srinivas on gait and imbalance. I'll quickly introduce Dr. Maja and hand it over to her. She's right now ENT and vestibulology doctor at Charles University Faculty of Medicine in Hradec, Karlo, Czech Republic. She's done a master's in otolaryngology from the same university. She extensively focuses on neurotology and has presented on various topics in neurotology in prestigious global platforms like IFOS, Paris, Barani Congress, etc. She's also organized courses in neurotology. Very warm welcome, Dr. Maja. I will hand it over to you and you can start off. I'm stopping my screen share now.
Okay. May I start?
Yeah, please.
Yeah, so thank you. I will share the screen. So thank you very much for introducing me, and many thanks also to the Cyclops MedTech for managing these vestibular webinars in this difficult time of lockdown all around the world. My topic for today's lecture is 10 steps protocol for acute vertigo, which we have done together with Alfargal Mohammed and also Solara Sino, or better to say
Hello,
that.
Madam.
Hello, can you hear me?
Hello, Dr.
Yes.
Maja.
Yes.
There seems to be a lot of audio disturbance.
But my internet is running very well.
I think it is
Background,
fine.
there is some noise.
So I think it's fine.
Okay.
So is there any problem? Can you hear me?
Yeah.
Yeah?
Yeah, we can hear you.
Yeah, so I can go on.
Yeah, please.
Yeah, so my topic for today's lecture is 10 steps protocol for acute vertigo, which we have done together with Alfargal Mohammed and Solara Sino, or better to tell that it was the idea of Alfargal Mohammed, and we joined him together with Solara Sino, and we have updated the protocol together as well. So first, before starting with the protocol, I would like to open the wide field of acute dizziness and vertigo differential diagnosing process. So what are the main aims of our examination? First, we should conclude if the patient complaints are from vestibular or non-vestibular origin, which is mainly the task for emergency department physicians. And if they conclude that the patient problems could be from vestibular origin, then comes our time, and we should localize the lesion and also distinguish serious from benign causes. On this slide, I would like to show you most frequent causes of acute dizziness or vertigo. As you can see, dizziness or acute dizziness accounts for 4% of emergency department visits, which means about 50 to 100 million indoor patients worldwide annually. Here you can see the list of the most frequent causes of acute dizziness and vertigo. And you can see on the first place, there are vestibular causes with about 33%. But what is emerging is that on the second place, there are cardiovascular causes with about 22%. On the third place, there are more than just one cause. There are neurologic causes, respiratory causes, metabolic causes, poisoning. Then comes the other psychiatric, digestive, genitourinary, and infectious causes as well. what should we always take in our minds that about more than 15% of all of these causes are from the dangerous causes. Here is another slide about the etiology of acute dizziness and vertigo, which is from Andreas Zwergel from 2019. And once again, you can see it's very similar scale. And once again, on the second place, there are cardiovascular causes. When speaking about the epidemiology of acute dizziness and acute vertigo, I would like to highlight also life-threatening conditions. From neurology causes, we are mostly aware of strokes, but we should be also aware of traumas, of infectious causes, of intoxications and seizures. When speaking also about non-vestibular causes, we should be aware of cardiovascular causes, from pulmonary causes, from metabolic causes as well. Now, as we know from epidemiology and also from life-threatening conditions that cardiac causes are common, we should always first rule out cardiac cause. This is one of the main messages I wanted to tell you, because we are sometimes so focused on autoneurologic causes that we can miss some dangerous non-vestibular cause. Therefore, we should always be aware if the patient was evaluated according to pulse, blood pressure, and electrocardiography as well. Sometimes associated symptoms will lead us to the correct diagnosis, and also these associated symptoms can help us to differ vestibular from non-vestibular causes. These associated symptoms can be, as you can see, fever, for example, fever, severe headache, stiff neck, muscle pain, sensitivity to light, and confusion, which is common in meningitis or meningoencephalitis. And the similar causes and the similar symptoms can be also like severe headache, stiff neck, sensitivity to light, and confusion is in subarachnoidal hemorrhage. Sometimes the associated symptoms will lead us to non-vestibular causes like chest pain or back pain, which will lead us to think about a cardiac ischemia or hypovolemic shock. Or sometimes hypoxemia and cough can lead us to the diagnosis of severe pneumonia. But what we are always searching for are also associated otologic symptoms as ear discharge, ear pain, ear pressure, hypacusis, which can lead us to differential diagnosis of otitis media chronica, cholesteatoma, labyrinthitis, Meniere's disease. But sometimes will be the vertigo the main symptom. Sometimes this vertigo as the leading symptom will be the most challenging task for all of us. Also, this situation can be present typically, for example, in early stage of posterior fossa strokes. So our aim is always in a presence, let's say, isolated vertigo complaint, to rule out also the stroke. Here you can see which I mean ica-pica and superior cerebral artery stroke. And also vertigo as a leading symptom can be in traumas like subarachnoidal hemorrhage or vertebro-basilar dissection, which is common in younger patients, and in Wernicke's encephalopathy as well. So once again, if obvious cardiovascular causes were ruled out, the cerebrovascular cause is the next step, also the next life-threatening condition which we would like to exclude, and that's also the reason why we should be familiar with stroke warning signs. Here you have some mnemonic to remember, which is FAST, which means face drooping, arm weakness, speech difficulty, and time to call emergency. But we should also have in our minds that these stroke warning signs are especially focused for the anterior fossa strokes. Now we know the stroke warning signs, and now we can move to the evaluation of the severity of stroke, which are neurologists familiar with. The most frequent used scale for assessing the stroke severity is National Institute of Health Stroke Scale, which is the most frequently used scale when assessing the severity of stroke. It has about 42 items, it's 42 item scale, and when the score is more than 11, it could be an accurate predictor for large vessel occlusion. Neurologists also use this scale when deciding about the treatment. But once again, this scale is unfortunately weak when assessing the posterior fossa strokes. I would like just to show you the scale because me as being an ENT doctor, I'm not so familiar with these scales, so I want to show this scale to any other ENT doctor. And what I miss here in this scale as being ENT specialist, I miss here, for example, nystagmus evaluation and gaze ataxia evaluation, which is the most common symptom in posterior fossa strokes. So this scale is very good for anterior strokes, but in posterior strokes you can take the score about 0 to 4, but at the same time the functional disability will be severe. Now, what can we use for assessment of posterior fossa strokes when we know that the NIHSS stroke scale doesn't work as well for posterior fossa strokes? We can use the modified ranking scale for neurologic disability, which could sometimes neurologists help to decide if they should use, for example, intravenous thrombolysis when NIHSS stroke scale has a low score. I also wanted to show you this very nice scale, which one colleague from Czech Republic, Pavel Dušek, showed me. It's very nice, the Israeli vertebral basilar stroke scale, which I think could be very useful when evaluating the posterior fossa stroke. But I would like also to see in this scale the evaluation of central type of nystagmus as well as being scored. It would be much more better, but I think this scale is one of the most beneficial for otoneurologists. Now we should move to transient ischemic attack description, which is also one of the conditions we are frequently facing with. Transient ischemic attack, I will call it TIA or TIA, yes. It's called as a mini stroke. It's a brief episode of neurological dysfunction of a vascular cause and typically lasts less than 1 hour. At maximum, it can last about 24 hours. There should be no evidence of infarction on any imaging. So its tissue-based definition is based on negative MRI, not on time of the attack. That's also the reason why it's difficult to differ MRI negative stroke from TIA in first 24 hours. For TIAs, there is very good and important protocol, which I would like also to show you, which is stratifying the risk of potential upcoming stroke after TIA. This TIA protocol is called ABCD2, and as you can see, it's a tool for identification of the patients of high risk of stroke following the TIA. Maximum score is 9, and when you have score more than 4, you should administer the patient with antiplatelet agents as aspirin, and if there is atrial fibrillation present, you should admit him with anticoagulants as well. If the score would be more than 6, the patient may be admitted to as an indoor patient, because there is a high risk of stroke in a few days. As you can see at the table below, 2-day risk and 7-day risk and 90-day risk of stroke after the TIA. Now I will move to our otolaryngology emergency vertigo protocols. We have, I think, these 5 protocols are the most famous and well-known and the most frequently used protocols. But I would like to highlight that these protocols were done especially for emergency department. So that's also the reason why we have established our 10 steps protocol. It's also the mixture of these, but also our protocol, I think, is providing more deep insight into the vestibular deficit as well. But we will discuss just a few words about these protocols that are very beneficial. As you can see, almost all of them, the first 2 and the last 2, were done from the group of Newman-Tucker. First the Kata, Newman-Tucker, the second one, Hinz Plus, also from Newman-Tucker, Titrate and Attest, also from Newman-Tucker group. But the standing protocol, which is very beneficial, is from Italian group, from Esvani. Now I will have just a few words about the Hinz protocol, which is the triad of head impulse, nystagmus, and test of skew, which was updated 4 years later with the Hinz Plus protocol, which also was improved with the hearing evaluation as well. Now we will move to standing protocol, which I said it's from the Italy group. It's a very, very beneficial protocol because this protocol is also evaluating the gait, ataxias, standing, walking, everything we should also consider. So they just changed the test of skew, which was very difficult in emergency department physicians to evaluate. They changed it to gait and standing evaluation. And then just a few words about titrate protocol, which is based on timing, triggers, and target bedside examination. And this protocol is triaging the patients between 4 major syndrome categories. And according to categories, they decide which target bedside examination will they do. Here is one table which is evaluating the sensitivity and specificity of this protocol for emergency departments. And as you can see, the Hinz is the best, has the best sensitivity, specificity, and the second one is standing. And now we are coming to our 10 steps protocol, which I would like to introduce you. As you can see, we have very nice design did from Solaracino. So let's go for it. What do we examine? We examine in our protocol 2 main vestibular reflexes, and we also do many otologic and neurologic tests. We can do this 10 steps protocol just by clinical examination, but we can also do it by sophisticated instrumental examination. The first step, now we will start with the first steps, with the first step of the protocol, which is awake, alert, and 4 times orientated. And the second part of the step 1 will be the history. First, I would like to tell you just a few words about the consciousness and mental status evaluation, as transient loss of consciousness can be present at stroke, subarachnoidal hemorrhage, and seizures, and in non-vestibular causes, it can be present at arrhythmias, acute coronary syndrome, aortic dissection, pulmonary embolism, vasovagal syncope, or hypovolemia. Altered mental status can be present at strokes, encephalitis, seizures, hypertensive encephalopathy. Also at Wernicke's encephalopathy and alcohol intoxication, drugs, and carbon monoxide intoxication as well. Now we will move to the second part of the step 1, which is history, risk factors, and also vascular risks. Vascular risks you can find at the blue table at the right bottom of this slide. You can see we should take in care hypertension, cardiac disease, diabetes, hyperlipidemia, cigarette smoking, alcohol consumption, and many others, as you can see. But we should always focus on previous history of transient ischemic attack, stroke, or any thromboembolic disease, or irregular heartbeat and atrial fibrillation, and also about antiplatelet therapy or anticoagulation. We should also focus on a history of any head trauma in previous, I would say, 1 month. We should also focus on severe headache or severe posterior neck pain, on migraine, especially with aura. And there is also one nice ABC stroke protocol from Hijazi from 2014, which is evaluating the age, biomarkers, and clinical history of prior stroke or TIA. And he is evaluating the score, which is very suspicious of as a vascular risk. We should be also aware of associated symptoms, which we were discussing, I think, on the 4th slide. Here are once again, the same table at the bottom, and up there is stroke risk scorecard, the same vascular risk factors like blood pressure, atrial fibrillation, smoking, cholesterol, diabetes, exercises, diet, stroke in family, and everything you will score. You will have total score, and you can predict if it's high risk or low risk of the vascular cause of the disease. Now we will move to the step 2 of our 10 steps protocol, where we will evaluate the nystagmus. Now it's time to mention that there are 2 very nice and beneficial presentations from Vishal Pawar and Avinash Bijlani, which were already in these lockdown sessions. So you can watch these videos, and they had said many things about nystagmus evaluation. So we will move to the nystagmus. I will just briefly introduce the nystagmus patterns. So spontaneous nystagmus is a spontaneous symptom of vestibulo-ocular reflex lesion. We will observe it with and without the fixation, and if it's from peripheral origin, it should follow the Alexander's laws. Here I would just like to highlight that when there is good suppression of visual suppression of spontaneous nystagmus, it means the flocculus is working properly, because sometimes I heard that there is good suppression of spontaneous nystagmus, so it should not be from central origin, but that's not true, because also very good visual suppression can be in central origin. That's only the reason why I'm highlighting this, that good visual suppression is the task of flocculus, not from the whole central system. We should always describe the patterns of nystagmus. We should describe the direction. For example, for the spontaneous nystagmus is beating to the left or to the right. It's upbeating nystagmus, downbeating nystagmus, and we should also describe the torsion. Everything should be described from the patient's perspective. I think the most challenging from this is to describe the torsion from the patient's perspective when speaking like clockwise and counterclockwise. So the best way how to resolve this is to describe the upper pole eye torsion, if it's beating to the left or to the right. And we should also every time describe the degree of spontaneous nystagmus. First degree, the nystagmus is beating in direction of fast phase of nystagmus. The second degree, it's also present in the primary gaze, and the third degree, it's present in all gaze directions. In a peripheral vestibular lesions, nystagmus doesn't change direction in all gaze directions. So here I would like to show you the video, but first I have to disrupt this presentation to change the video patterns. Do you hear me? I hope so. You hear me?
Yes, ma'am. Yes, ma'am. You can do.
Yeah. So I will just stop sharing. I will change the patterns and then I will share once again. So please just hold online.
Yes, ma'am.
Yeah, thank you. Stop share. Share screen. So now you can see, I hope, do you see it? Do you see it well? Can you see it?
Yes, ma'am.
Yeah, it's right beating nystagmus. As you can see, it's from peripheral origin. It's right beating, a little bit torsional. Upper pole is beating also to the right. And it's third degree spontaneous nystagmus, as the patient will look just to the third degree direction, and we can see it didn't change the direction. So it's from peripheral origin, third degree, right beating spontaneous nystagmus. So now I will just once again disrupt because I have to change once again the slides
Yes,
for
ma'am.
you to see the text. Thank you. Just stop share. So I'm back. Do you see it well? Everything is okay? Please just...
Yeah, it's okay, ma'am.
Yeah, thank you. But sometimes here is not... Sometimes, I don't know what happened. So I will have to do it once again. I have some problem with going on with the presentation. Just few seconds.
Yes, ma'am.
I don't know. I don't know what happened, but I can go on in presentation.
Ma'am, you can use the
It's
keyboard
frozen.
also.
It's frozen. I don't know why it's frozen now.
Ma'am, you can restart, ma'am. You can restart the presentation.
Restart the presentation. I'm trying to escape the presentation, but...
Yes, ma'am. You can escape and then come to...
Yeah, so I will stop sharing and wait a second. Yes, wait a second. I will be there. I will share the screen once again. I hope it will run. Yes, is it okay?
Yes, ma'am.
Yeah.
Yes, ma'am. It's okay. Perfect. Ma'am.
Super. So we can continue now with always spontaneous nystagmus evaluation. So we can examine spontaneous nystagmus just by using Frenzel goggles or M goggles, which are from microstraps goggles or many other devices, or we can use more sophisticated instrumental devices as ENG or VOG. Then we will move to Gait test, which is the test with visual fixation. We ask the patient to look at 5 gaze directions and to fixate the steady target and maintain the gaze for at least 10 seconds. We should always rule out the gaze pulses, diplopia, horizontal and vertical, and we should always also rule out gaze-evoked nystagmus, which is changing the direction with the direction of the patient's gaze. So when he is looking at the right, it's right beating. When it's looking to the left, it's left beating. And we can also rule out internuclear ophthalmoplegia, where ipsilesion adduction would be impaired. And we can also rule out 1.5 syndrome, where only abduction on contralateral eye is spared. In both of these last mentioned syndromes, there is also disconjugated nystagmus in abducting eye. And we can also evaluate the visual field, as we can check we can ask the patient if he sees all the visual field or is there any hemianopia. Now we will move to some videos. So I will once again have to stop the sharing. Once again, we'll have to change the pattern. So please just once again hold the line, stop share. So we can continue the first video. This is the video of gaze-evoked nystagmus. You can see the lady is looking to the right beating nystagmus occurs, and then she is looking to the left, and nice left beating nystagmus. At the central gaze, nothing happens. You can see the eccentric position is not so large. Just a slight eccentric position of the eye is sufficient. And on the second video, I wanted to show you, as you can see, few beats to the right. And then we ask patients to look at the direction of the nystagmus, which according to Alexander's law should be increased, but the nystagmus diminished at all. It was acute attack of vestibular migraine, but unfortunately it ended at the time I was doing recording. The next video is from the lady with downbeat nystagmus. As you can see in the primary gaze, there is weak downbeat nystagmus, but we will see it much more better in lateral gaze. As you can see, looking to the left, huge downbeat nystagmus. And when she is looking to the right, also once again, huge downbeat. The last video from this slide, just once again on the primary gaze, just weak downbeat, and on the left gaze, as you can see, gaze evoked. Changing direction in the direction of the gaze. Now I will show you 2 more videos. As you can see here, you can see it looks like peripheral vestibular nystagmus, and it was also described as peripheral vestibular nystagmus from emergency department, right beating, third degree. But what happens here? As you can see, it slowed down, from upbeat, and now you can see it's changing direction. The next video is the same lady, just I have to do the new recording because I have recording for 20 seconds. So this is the same lady, and the nystagmus spontaneously changed direction. So it's called periodic alternating nystagmus. It was 42 years old lady, no vascular risks. First, she had the diagnosis of vestibular neuritis, but when we have seen this periodic alternating, we realized it should be nodulous lesion. Now I will show you two more videos about head shaking test, which in peripheral vestibular lesion should increase average slow phase velocity of spontaneous nystagmus. I will run the first video, and the second above or under the first is the head shake. As you can see, I'm moving with the head and also with the eyes are moving. And then you will see the increase in intensity of the previous spontaneous nystagmus. As you can see now, the lower nystagmus is more frequent as the first one. So it's from it should be from peripheral or could be from peripheral origin. In central lesions, it can change the direction. It can be perverted nystagmus as well. So now I think the next slide is without the video. So once again, I will stop the sharing and change the patterns of my presentation for you to see the text. So once again, stop share. Sorry, once again, I have to escape from Yes, I will continue in a few seconds. Share. Yeah. Oh, so sorry. It's not that. Stop sharing. Yeah. Yes. Back. Do you see it, please?
Yes, ma'am.
Yeah, super. So at the end of the evaluation of the spontaneous nystagmus, just we can do the positional testing, especially in the cases when there is no huge spontaneous nystagmus. We can evaluate the few positions to see, for example, the latent nystagmus, or we can.
Ma'am, can you come closer to the mic, ma'am?
Can you hear me?
Can you come closer to the mic?
Yes, I'm at the same distance for all the presentation. Did anything change in audio?
Yeah, ma'am, little feeble, ma'am.
Do you hear me now?
Yes, ma'am, we can hear you, ma'am. Continue, ma'am,
Yeah.
continue.
So in acute dizziness or vertigo, also positional testing can be beneficial, especially where spontaneous nystagmus is not present or is weak. We can do also positional testing. And now we are coming to step 3. Do you hear me? I hope you hear me. It's head impulse test. Head impulse test is a high frequency vestibulo-ocular reflex of all the 6 semicircular canals in the physiologic frequency of head movements, which is about 3 to 5 hertz. We can perform it as a clinical test, as head impulse test, and we can also perform it as instrumental video head impulse test. Here is the description how we can perform the test, that the patient is sitting upright with visual fixation of the spot in 1 to 2 meters distance. The examiner grasps the patient head and moves it briskly and unpredictably for the patient. The peak head velocity of the impulses should be more than 150 degrees per second, and amplitude of head movement should be 10 to 20 degrees. Here I would just mention that when we are doing or performing video head impulse test, it's just sufficient to do the 10-degree movement, but when we are doing clinical head impulse test, we need more movement or larger movement to observe the corrective saccades. When there is a unilateral vestibular lesion, in that time eyes do not compensate for the ipsilesional head turn and therefore slipped off the target. By the end of the head turn, a corrective saccade occurs to return the gaze back to the target. So what we are as clinicians are always looking for when doing head impulse test is a presence of corrective saccades which occur immediately after the head has stopped. This is also the only thing we can evaluate with our eyes when doing the head impulse test, because our eyes are not as beneficial in detecting all the head turn as video camera, which is high frequency and high frames, and camera has much more better evaluating patterns than our eyes. So we can evaluate in clinical head impulse test just the presence of overt correct saccades. If the vestibulo-ocular reflex is unaffected, then no corrective saccade will be present. And if vestibulo-ocular reflex is affected, we should observe the corrective overt saccade immediately after the head has stopped. Here I have also just once again one beneficial video. So I will just once again, it will be just complications, stop sharing, just once again have to change the patterns, optimize screen sharing for the video clip, once again share. So optimize. Yes, I am here. So now I would like to show you the video of this lady where you can see the corrective saccades to the left, and the corrective saccade was here is also to the right doing head impulse test. Here you could see the corrective saccades were for both sides. Maybe I could just rewind it once again. To the left, as you could see, there was corrective, also corrective, also corrective. Once again, 4 corrective saccades. The 5th one was not so good seen, but you could see it very well. Now I will just once again escape from the sharing of video. Just wait a second. I have once again escaped from my presentation. Super. I'm coming back. Just hold on. Share the screen. Without share. Yes. So now we are moving to video head impulse test. Fortunately, we have video head impulse test, which provides us much more information than just clinical head impulse test. Video head impulse test provides also information about all of the vestibulo-ocular reflex. Also, it provides calculation of vestibulo-ocular reflex gain. We also see graphic visualization of the whole vestibulo-ocular reflex, and we see every overt or covered saccade which occurs. So we can see these covered saccade, which we can see at the below and on the second. I don't have any. Oh, I can show you here. Here, do you see it? I hope you see the point. My point. This is the covered saccade, which we wouldn't see when doing head impulse test, because these saccades are hidden in the head turn, as you can see. So fortunately, to video head impulse test, we can see the gain of vestibulo-ocular reflex, which is decreasing in the vestibulo-ocular reflex lesions, and we can also see every saccade in every head turn. Now, I would like to stress you that in the presence of spontaneous nystagmus, if the HIT or video head impulse test has a normal result, it's a strong indicator of central cause. And in the presence of spontaneous nystagmus, if there is abnormal HIT or video head impulse test, it's indicator of peripheral lesion, but weak to localize the lesion because we cannot exclude central cause. As you can see, I have two strokes written below pica and ica. In pica, there is normal head impulse or video head impulse test, and pica also spares the hearing. But in ica, it's HINS positive, HINS plus positive. It means that there is positive abnormal head or video head impulse test, and there is also a decrease in hearing. So it's HINS plus protocol positive. Now moving to the step 4, which is the test of skew. The test of skew is one of the most very beneficial tests. Also, it's the one part. Skew deviation is one part of triad, which is from otolith pathway lesions, and this triad is skew deviation, ocular torsion, and tilt of the head. How can we examine the skew deviation? The skew deviation, which is hyper and hypotropia of both ears, of both eyes, sorry, we can examine it by alternating cover test. And also, skew deviation is a strong indicator of central otolith pathway disruption, but can be also present in peripheral vestibular lesions as well. But it's a strong indicator of central otolith, especially in cases where the V-hit or hit was normal. So now just a few words about subjective visual vertical, which perception is also related to ocular tilt reaction. We can measure subjective visual vertical with some devices like bucket test, and there are also sophisticated subjective visual vertical devices we will be discussing later. So I will show you on the next slide once again the video of the skew deviation and how to examine it. So I once again have to stop sharing. Now you will see the patient with huge skew deviation. You see the left eye is going up, the right eye is going down, and there is also spontaneous right beating nystagmus present. You can see right eye coming down, this one is coming up. And you can see the best is seen on the left eye, which is huge movement, vertical movement up. The alternating particles. Yeah, once again, I should stop the sharing because I want you to see my slides well. So once again, escape from the presentation. Yes, once again, share without optimizing. So I'm back, and yes. So when there are doubts, if there are doubts about also presence of superior oblique palsy, we can use or perform upright supine test for skew. The patient just lies down, and if the skew decreased more than 50%, it should be skew deviation, not superior oblique palsy. And just how can we evaluate the subjective visual vertigo? As we were talking, it's this perception of subjective visual vertigo is related to ocular tilt reaction. We can use many devices as bucket test, as you can see here, and also there are some other sophisticated devices for the evaluation of subjective visual vertigo. Here is one slide where you can see just subjective visual vertical tilt direction according to localization of the lesion. As you can see from the peripheral vestibular end organ to pontomedullary vestibular nuclei, it's ipsilesioned with subjective visual vertical tilt, and above it's contralesioned. Now we move to step 5, which is standing. Our mentors were always telling us that who can walk can go home, and I think it's nice rule. And also grading truncal ataxia from 2016 reflects this rule as well. There are 3 grades of truncal ataxia, which with grade 1 it's mild to moderate imbalance with walking independently. Grade 2 means there is severe imbalance with standing. The patient cannot walk without support, but he can stand and he can sit without support. And grade 3, which means that there is falling at upright posture and also falling while sitting unassisted. And what is interesting, grade 2 and grade 3 has huge sensitivity but low specificity for ICAS and PICA strokes. And grade 3 was found only with central acute vestibular lesions. When speaking about the truncal ataxia grading, we can evaluate the patient just by sitting, then by standing, and then we can turn to do the other, or we can perform the other tests for evaluation of vestibular spinal reflex and cerebellar testing. We can do Romberg stand, Orton, Unterbeck Fukuda step test, Babinski-Weil test, standing or walking, and walking and turning. Here I have also the video, but I will show you like this because I think it's so slow that maybe you will see it. Do you see it a little bit how the lady is walking? I hope yes. Can you see the video, please? Do you hear me?
You can see the video.
Yeah, super. Thank you. And now we will move to the step 6, which is screening for dysarthria, dysphonia, dysphagia, dysmetria, dystaxia, dystonia, dysdiadochokinesis, dysesthesia, and dysappropriate limb movement or muscle tone. First, we will just examine the cerebellar and bulbar dysfunction, if there is some dysarthria or dysphonia, or dysphagia, if there is some dysmetria, dystaxia, or dystonia, by Ortant, Mingazzini test, finger to nose, finger to finger, knee shin, Stewart-Holmes for rebound, patellar reflex, dysdiadochokinesis, and dysesthesia, with especially ipsifacial pain or temperature hyperesthesia, which are common in pica strokes. Here is also one video of rebound. While normally the patient should be sitting, but I am doing it also when standing. So it's a Stewart-Holmes rebound of the arm. As you can see, she would fall down if she would not have support. Now she will be searching for any support because she's afraid she will fall. As you can see, she has support. I didn't know it, but she has support with the hand. Yeah, and once again, she would fall.
Výborně. A teď řekněte, jak se jmenujete, nebo jak dlouho máte problémy.
18. listopadu.
A co se stalo?
Přestal jsem chodit.
Přestala jste chodit? Motala se hlava?
Ne, jen nohy.
A řeč se změnila?
Řeč jsem měla. Nevím, čím dal.
Se změnila, že je hůř rozumět.
Ano.
Her speech is also many troubles with speech. And here's finger to finger test with huge ataxia. And then we should always search for motor deficits, and we can grade the motor function to a grade 1 to 3, with 1 means the holding of the limbs, arms and legs is okay. The grade 2 means the limb drifts, but there is effort against the gravity, and grade 3 would mean that there is no effort against the gravity. And now we are moving to the step 7, which is a central oculomotor test, smooth pursuit, saccadic eye movements, a suppression of vestibulo-ocular reflex. First, the smooth pursuit, we ask the patient to follow a moving target along either the vertical or horizontal plane with constant velocity. We can examine horizontal or vertical plane, and and the smooth pursuit is intact in peripheral vestibular syndromes, although the assessment may be difficult according to presence of spontaneous nystagmus. And in central causes of vertigo, the smooth pursuit is broken or jerky or saccadic. I would like to show you this video, so once again I have to stop the sharing because it's about the nystagmus and we need to see the video clearly. So once again I will stop sharing. Now we'll return, and now I will show you. This is the smooth pursuit of the patient with acute peripheral vestibular lesion with the left beating nystagmus, and as you can see, when she's doing the smooth in the direction of the slow phase, it's just torsion, like now that you can see the torsion movement. But when she is looking in the direction of fast phase of nystagmus, there are many intrusions of saccadic eye movements because of the spontaneous nystagmus. So sometimes it's very tricky to evaluate the patient with spontaneous peripheral nystagmus as well. Now I will once again stop sharing because I once again need to change the slides for you to see my presentation. Escape. Yes. Once again, share. Share, and I'm back. Now we can move to another slide, to saccadic eye movements, which can be examined in horizontal and vertical plane as well. Saccadic eye movements, the patient shift the gaze quickly between different earth fixated targets, and especially in central lesions like cerebral or brainstem lesions, saccades can be hyper or hypometric. Now, few words just about the suppression of vestibulo-ocular reflex. We can perform this test especially when we are not as sure as we would wish to be when evaluating the spontaneous nystagmus patterns. I mean, when thinking about the suppression of spontaneous nystagmus by visual fixation, if it was really as we think. So if we are not sure about the suppression of spontaneous nystagmus by the visual fixation, we can perform also this test, suppression of vestibulo-ocular reflex, to be sure. It's something like cross-check our findings. And the suppression of vestibulo-ocular reflex is a task for flocculus and paraflocculus. So if these structures are impaired, there is not suppression of vestibulo-ocular reflex. Now moving to the step 8, which is screen for BPPV. Especially if there is no spontaneous nystagmus, when there is no spontaneous nystagmus present and the history suggests for BPPV, we should always try to do BPPV maneuvers in acute vertigo or dissipation. We can do it just clinically, just by our eyes, but without any device, but more beneficial would be to use Friends goggles or VOG. Here, I wanted to show you I think, good mnemonic for the most frequent BPPV syndromes, which tell us that the strongest positioning induced nystagmus is beating toward the affected side, as you can see here on this slide. We can move to step 9, which is screening for cranial nerve dysfunction. During the previous steps, we have evaluating the vision in the gaze test. We were discussing about just evaluating the vision, and also we were evaluating oculomotor nerves as well as the 3rd nerve, 4th nerve, and the 6th nerve in gaze tests. And now we also should focus on evaluation of remaining cranial nerves. I mean, especially on cranial nerve 5th, 7th, and bulbar system, because 8 we are evaluating in all our examinations. We should focus once again on bulbar system, and we should exclude dysphagia, dysphonia, dysarthria. We should also focus or exclude Horner's syndrome, which can occur in pica stroke, which is meiosis, ptosis, and anhidrosis. And once again, what we should not miss, it's facial dysesthesia, which is from the 5th cranial nerve, which is common in pica, and it's ipsilesioned. In pica, there is loss of pain and temperature sensation in the ipsilesioned facial region, and there is contralateral sensory deficits of trunk and extremities, and there is also ipsilateral deficits of other cranial nerves and vestibular nuclei. And we should also not miss palatal tremor, dysphonia, dysphagia once again, so bulbar involvement, and also palatal tremor can be caused by inferior olivary hypertrophy or cerebral atrophy. I will show you just once again one video. I will stop sharing once again. Just to show you this video, which is with the video of palatal tremor. Once again, I would like to highlight the bulbar palsy effect, which affects the 9th, 10th, and 11th and 12th cranial nerve, and is often due to lower motor neuron pathology. I will once again escape the sharing because we will move not with video. Stop share. Wait a second, I will continue in a few seconds just to escape this. Once again, share. So we are back. Yes, also I just wanted to tell a few words about the bulbar paresis, bulbar palsy, that it can present also not just dysphagia, dysarthria, but flaccid paresis, atrophic or fasciculation of muscles supplied by these cranial nerves and trunk fibrillation. As well, we can observe also some weakness of the palate and reduced or absent gag reflex and nasal speech and dribbling of saliva. Step 10 is the last step of our 10 steps protocol. It's the hearing evaluation step, and let's go for it. Us as being ENT specialists, we always are focusing on ear symptoms. So we as being ENT will always search for any ear history, some ear discharge, ear pressure, hypoacusis. We always evaluate the otoscopy to exclude the cholesteatoma, especially at atticus, otitis media acuta, or with effusion, and also hemotympanion after some head trauma. We also should always perform tuning for tests and also audiometry and tympanometry. Now we will evaluate some typical audiometry findings, but I have to highlight that I have excluded the conductive hearing loss and audiograms, which are for especially ENT diagnosis, as previously mentioned, otitis media acuta with effusion, cholesteatoma, and their complication, which can lead to labyrinthitis. And I have also excluded for this presentation audiograms with the third window syndrome, which are associated with Julio phenomenon. I just wanted to show you just few audiograms which are especially of sensory narrow hearing loss. So here is the first audiogram. It's a normal audiogram, and we expect this normal audiogram in superior vestibular neuritis and in BPPV. Sometimes we can observe typical audiometry finding, which shows us the future diagnosis of endolymphatic hydrops, and is also accompanied by the other symptoms as pressure in the ear with tinnitus. So you can see the typical audiogram from the Menias patient. Here is one typical audiogram with basocochlear sudden sensory narrow hearing loss. It's high frequency sensory narrow hearing loss, and when this sensory neural hearing loss is present with downbeat nystagmus and posterior canal involvement on video head impulse test or head impulse testing, we suspect the inferior vestibular neuronitis, especially of vascular cause. And if the same audiogram we see in the patient with horizontal with torsion spontaneous nystagmus, we can also think about the vestibular schwannoma decompensated stage, especially in grade 2. The vestibular schwannoma are going to be decompensated and can show us audiogram with acute peripheral vestibular lesion. And the last example of audiogram is here. This is the sudden onset of profound sensory neural hearing loss associated with acute peripheral vestibular lesion. This audiogram accompanied by acute peripheral vestibular lesion is a huge suspicion of the vascular cause of the compliance of the patient. So once again, our 10 steps protocol, as you can see, we have now gone through all of these steps, and just the last slide is the slide about the safe to go home features. You can dismiss the patient to go home in where there is no evidence or in absence of all these signs that are written below. It means there is no normal head impulse test in the presence of spontaneous nystagmus. There is no skew deviation. There is no diplopia. There is no any central type of nystagmus. There is no truncal ataxia grade 3. There is no cerebral dysfunction. Then there is no cranial nerve deficit, and there is no sudden and profound pancochlear sensory neural hearing loss. So thank you very much for your attention. I don't know what's the time and if I'm on time.
Yeah, you are almost 17 minutes ahead of schedule. So
yeah.
Thanks a lot, Dr. Maja. I think questions can be taken towards the end once Dr. Srinivas finishes his session.
Yeah.
Thank you. So I'll just share my screen now to introduce Dr. Srinivas. Yeah. So very happy to introduce our co-founder at Cyclops MedTech, Dr. Srinivas Dorasala. So he's a ENT surgeon neurotologist, and he's one of the founders at Cyclops MedTech, creators of Balance Eye, VNG, and video oculography system. So to put it in a nutshell, there are 5 aspects which kind of describe him. You might have heard of encyclopedia, Wikipedia, etc. So we can actually call him a vestibulopedia. He's a walking, talking vestibulopedia, stunning people with his vast understanding of the topic. He's an innovator par excellence. He's created multiple devices, and if you visit our office, you can see that one day he's explaining complex mathematical models using calculus. The next day he's actually playing around with circuit design. Sometimes it's very hard to believe that what exactly is he? He's a doctor, he's an engineer, he's everything actually. He's a great teacher. Last year almost he's actually traveled and taught in almost about 65 to 70 platforms. And he encourages interns at any point of time in our office. You'll see multiple interns getting trained under him. Like I already mentioned, he's the one who's designed and developed Balance Eye VNG system, which is India's most popular video nystagmography, video oculography system now, with more than 250 installations. And he's also developed Balance Eye VRT, the virtual reality-based rehabilitation device. And there are a host of other products in the pipeline which will be unleashed soon. And lastly, he's a wonderful human being. So over to Dr. Srinivas Dorasala.
Very good evening to everybody. So this presentation, I mean, this topic I've taken for because of my personal pains in dealing with certain categories of patients in whom everything turns out to be normal. We evaluate them, we see that everything is normal, and then we really don't know what to do about those people. So that is what prompted me to actually read about this, and then I decided to present this. This is something like a presentation which I have made to help myself. So not out of expertise or anything. This is more to make things simple for myself. This presentation I made, and that is what I'm going to present. So you may be thinking, what is this gait and imbalance? How are they related? Why they have come in one presentation, and all those things. Okay. So when you see the requirements for normal walking, okay, so there are two things when we talk about requirements for normal walking. One is equilibrium and another is locomotion. So these two things, this theme will continue throughout the topic. So let us okay, internalize this. There is equilibrium, there is locomotion. What is equilibrium? The capacity to assume and maintain a stable upright posture in which the trunk is balanced on the legs during standing and locomotion. Okay, so upright posture, trunk balanced on the legs, both during standing and also during locomotion. All these things is equilibrium. Two is, okay, once you have maintained a upright posture and you have the capacity to actually maintain that upright, stable upright stance to move yourself forward, that is locomotion, the ability to initiate and maintain rhythmic stepping. These are the requirements for normal. Okay. Now, what exactly is? You saw two components. There was equilibrium, and another one was locomotion. In equilibrium, what are the things that are there? So the first thing there is a righting reflex. There are supporting reactions. There are postural reactions, and within the postural reactions, there is a hierarchical arrangement of anticipatory postural reflexes, reactive postural responses, rescue reactions, and protective reactions. So I'll go into each of those things and we'll keep coming to this again and again. So we need to just internalize this. Righting reflexes are there, supporting reactions, postural reactions. In the postural reactions, there are a hierarchy of responses. What exactly I mean by hierarchy, I'll explain. The first and foremost is righting reflex. What exactly is a righting reflex? So righting reflexes are known in lower animals. If you take a cat and drop it from okay, if you take a cat and drop it from the top and it falls down, even if the cat was, this is one very nice image that is present in the vestibular system Sixth Sense book. Okay, if it is dropped down in the air itself, it makes sure that the head comes up, the foot come down, and it lands correctly. So this is called a air righting reflex of the cat, which is there in animals. Okay, it is there. So righting reflex simply means that we have this ability, okay, to take an upright position. That is all. And human beings, the first thing is, before we locomote, from whichever position we are, we need to come and take up a upright position, from supine or any position, lying to the side, sitting, squatting, whatever it is. Ultimately, we need to get up with head up and into a straight. So, and that happens through coordinated muscle synergies, and these synergies are triggered by vestibular, visual, proprioceptive, or tactile stimuli. In a normal person, all these stimuli may not be enough. Even one may be enough to trigger that righting reflex.
Sir, your voice is crackling, sir.
Still, it is cracking?
Yes, sir. Yes, sir. You can
try to take the system a little closer.
Maybe you want to get closer to the router.
Till now, whatever I spoke was heard well?
Yeah, barring 5-6 seconds, I think it was fine.
Okay, now it is better?
Yeah, and also you can close your video. Yeah, now it's better.
Better,
I'll
sir.
stop my video. Okay.
Yeah.
I'll stop my video. If at any point of time, if it is not heard well, you let me know, please. Okay.
Okay, sir.
Okay.
It's fine.
Can you hear well now? It's fine.
Yeah,
okay.
yeah.
Righting reflexes from supine to any upright position, the head or body has to be brought. Okay. the extreme example was in the cat. When you drop it from top also, the head will come up, limbs will come down. So that's the righting. That righting reflex is present in us also. It is exerted through a coordinated muscle synergies. All of them will act together and make sure that that kind of thing happens. But here we refer to from any position coming to upright position. That is the first thing. Okay. Now, so that was the righting reflex. Now coming to supporting reactions. Once after you have done the righting reflex, and if you come to the upright stance, now you need to maintain that stable upright stance. So that is the supporting reactions, maintenance of upright posture, and this is happening through anti-gravity muscles. Till now things are simple. Righting response brings you to one state, then the supporting reactions, which are the actions of the anti-gravity muscles, their contractions will make sure that you actually stand in a upright position. That is maintained. First is reaching, second is maintaining. Till now everything is fine. Now, when you come to the equilibrium, first was righting reflex, second reaction, so reach the upright, stay in the upright. Now comes postural reactions. Here there is a hierarchical organization of postural reactions depending on the demands of what all will happen. The first one is in the lowest in the hierarchy or whatever is the anticipatory postural reflexes. So what is anticipatory postural reflexes? It happens through a feed forward loop. If you're not sitting, I can ask you, just stand up, try to lift up your right arm, and you will start noticing when you try to lift up your right arm, you start moving your trunk starts moving to the left. In fact, the trunk moves to the left even before the right arm is lifted. More so if you are carrying a weight, if you are having a suitcase or something and you try to lift the arm, even before you start lifting, you start swaying to the opposite side in anticipation of that lifted, so that you can still maintain that center of gravity between your base of support. Okay, this is a feed forward loop. In the sense, it does not happen afterwards. It happens in anticipation of that movement. So it is a feed forward loop. It is very, very manifest to that this is actually happening, where if you think that you are trying to, from our own experiences, we must have had those experiences where we try to lift something. It is called empty suitcase phenomenon, where you try to lift something and it turns out to be, it was not as heavy as what you saw. It was empty suitcase. So you suddenly feel, some lightness. That was actually because you had already prepared. Your anticipatory responses were already prepared for something heavy, and it was not. So you feel that very, very lightness. That is called as empty suitcase phenomenon, which is a part of the which happens that you experience because of the anticipatory postural reflexes. Now, in the next in the hierarchy is the reactive postural responses. So you are doing something, whatever it is with your hands, you're trying to reach out or whatever you are doing. After that, this is feedback loop. In the feedback loop means previous one was feed forward. It is going to happen before only the body starts swaying to one side. In the feedback loop, in reactive postural response, this is next in the hierarchy. So what happens? You are holding something, you are trying to reach something. Your body has started moving, and the center of gravity has moved a little beyond a certain range. The moment that happens, because of the stretch reflexes, all monosynaptic and polysynaptic reflexes that happen at the spinal cord level, ultimately the postural responses bring you back to a stable position. So the body is brought back to a stable position. This is the reactive postural response. Now, next in the hierarchy. So we saw in the hierarchy 1, 2, now the third one, the rescue reaction. This is very, very important, because in what we are going to consider today as a high level gait problem, the problem is in the rescue reactions. That is brain level, cortical level, basal ganglia level problems. The problem is here. In rescue reactions, see, after that, first one was anticipatory, next one was reactive. If these two things are not sufficient and you still are going beyond, you're going to about to fall. To prevent that, what you're going to do is, the previous two ones were trying to maintain the line of the center of gravity, okay, or the center of mass within the base of support, between the two limbs, okay, your right and left leg, so that between that you don't fall. The first two. The second one is, it is going beyond in this third one, rescue response. It is going. So what you are trying to do here is you do a stepping response, one of them. Okay. In stepping response, to bring the base of support under the new center of gravity, which means you try to take a step forward. You already started swaying forward or whatever. Okay. So under the new center of gravity, so that you take one step ahead. So previous two responses were about maintaining COG within the base of support here. In the rescue response, again, there is one more where you can't actually shift to a new base of support. Just imagine you are actually standing on the edge of a cliff and you are about to fall. At that time, you remember what happens when we are trying to about to fall. Do you remember like a windmill, we move our hands backwards so that we push ourselves backwards. So that is called windmill arm movements when stepping is inappropriate as at the edge of a cliff. So this is the next level in the hierarchy, that is the rescue reactions. Next level in the hierarchy after rescue reactions is protective reactions. You have done all these things. In the beginning, you did anticipatory. Okay. Then next you did reactive. Next you did rescue. In spite of all these things, there is no way you are going to avoid actually tripping off and falling. At that time, you do something called protective reactions, where when fall cannot be prevented by all previous responses, throwing the arm out and landing on the hand to prevent head injury, this kind of things. Okay. So this is what is going to happen. So these are the hierarchy. So I'll come back so that all of us, okay, this is rather than covering, I just want to make sure that we all internalize all these things. Okay. It doesn't matter how much we can cover in 1 hour. So we saw walking has two requirements for that. One was equilibrium, another was locomotion. Within equilibrium, we have the righting reflexes, the supporting reactions. Righting reflex to maintain get into an upright posture. Supporting is to maintain the upright posture when there is no other perturbation. Then postural reactions to take care of perturbations. One is anticipatory, when you know what is going to happen. Reactive, yes, you're doing something, it is beyond the anticipatory, so you do that. It is based on reflexes. Then there is the rescue reactions, which is stepping, the windmill response, all these kind of things. Then the last one is, when you cannot avoid a fall, the protective reactions. Okay. So I think this one concept is formed. Now we will go to the next one. So we saw again requirements for normal walking, equilibrium and locomotion. Equilibrium and locomotion are considered to be separate but interrelated components of gait. So when you talk about actual normal gait or any gait, there are two components to it, and this is what. One is equilibrium, another is locomotion. They are separate components, but they are very much interrelated, and those two components, interrelated components, is what contributes to gait. So when it comes to the next component, that is the locomotion. We finished off equilibrium, the locomotion. There are two things in locomotion. First one is the gait ignition. The next is the stepping. So what is gait ignition means? Ignition in the car, ignition is starting the car. So gait ignition, a starter signal is issued. This starter signal generally comes from the cortex. Okay. Once the starter signal is issued, now what happens? A redistribution of activity in the posturally active muscles set for the following sequence of action. So imagine that you are standing, a starter signal has been issued. Now what will happen? The center of gravity is shifted laterally to 1 foot. Okay. You are standing with 2 feet. If you have to start walking, it means 1 foot has to go forward, which means now you will have to, if 1 foot has to go forward, you will have to stand on 1 foot. So what has to happen? The center of gravity is shifted laterally so that it goes through that 1 foot so that the other foot can be raised. Now after lateral movement, the next thing will be to move the body forward. So to push the center of gravity forwards to allow the body to move forward onto the advancing foot so that you can start advancing forwards. So this is gait ignition. So it is ignited at the cortical level and then redistribution of posturally active muscles, which makes two movements, one lateral, another was forward. So in the locomotion, we have gait ignition and stepping. Now when it comes to stepping, Alternating coordinated movements of legs and trunk. Alternating coordinated movements of legs and trunk. Okay, the trunk moves, the pelvis moves, the legs move, all of them move, including hands move for us during the stepping. Okay, when you go forward. Okay, so now we saw the two requirements of walking. One was equilibrium, another was locomotion. Within equilibrium, we saw three reflexes and then their hierarchy of responses. Then we saw locomotion, ignition, and the actual stepping. When you talk about stepping, okay, we deal with what is called as a gait cycle. So stepping flows through something called gait cycle. So what happens is, now to make it very easy for us to actually study this, okay, so lot of people actually have come up with a nice classification of the cycle into different parts. So the gait cycle understanding, and that is very important for us to understand the gait cycle, to take the discussion forward and to make sure that what muscle works at what time, what joint moves in what way, all these things is very important. Based on that, it becomes very easy to make diagnosis of gait problems. And also to the rehabilitation. Towards the end, I will be talking about rehabilitation. What are all the things that are there that can be done to rehabilitate people with proper specific examples of specific exercise examples. So gait cycle. How does the gait cycle start? Now the gait cycle starts with something called a, okay, that with the heel strike. So starts with, so when you see in the extreme to the left side of my screen, here the person is starting, the blue colored limb, the heel is just touching the floor or the ground. So that is the heel strike, okay, or foot touch or whatever it is, depending on if you want to. Okay, in a normal gait, it is the heel that touches. Then after the heel touches, then what happens? The full entire foot becomes flat. So the heel touches. After that, the foot becomes flat and the entire foot comes in contact with the ground. Then there is something called mid stance, where the lower limb, the rest of the lower limb comes straight. Okay. And then there is going to be something called heel off. Okay. And then there is going to be a thing happens called as toe off. Okay. Toe off. So the heel off and toe off. When the toe goes off, then there is another step, that another phase that starts, and that is called as a swing phase, where the limb is now in the air. Limb is now in the air. So now you saw from here, from the left side here to the toe off, the limb is on touching the ground, and from that point onwards till the next heel strike, the limb is in the air. So the entire duration or of the cycle, gait cycle, where the limb was actually touching the ground to the toe off, that is called as a stance phase, and the other one is called as a the swing phase. So the limb does a stance and a swing. Within the stance, we saw several steps, and within the sting, there is an initial acceleration, there is a swing, mid swing, and there is a end deceleration, and again the heel strike, which again starts from here. So this is the gait cycle. Now, what is the difference between gait cycle in walking and gait cycle in running? Now let us see one more thing here. We saw from here to here, when you see, when the heel struck in the first place, during that time, the other limb had not yet lifted off into the air. So there is some amount of time when the other limb has not lifted off into the air. And towards the end, that the other limb swings and comes back and touches the ground, even when the blue limb is still touching the ground. So at that time also, the green limb has again come back and touch the ground. So there are two places, here and here, where there is something called both limbs are in contact with the ground, that is double support. Here is the place where there is only one limb contacting the ground, that is single support. So there is a double support and a single support. So this is what it is. So when one limb, the right limb here is in single support, so the other limb will be in the swing phase. So single support of one limb is actually swing phase of the other limb. So this much we need to know. Okay. What happens when it comes to, so we saw double support, these kind of things, and there is a swing phase. When it is in running, you see there is something called float. Means there is a time where there is zero support. In walking, there is double support and single support. There is no zero support here. Whereas when it comes to running, there is a situation where there is going to be, you're actually in mid-air, that is called float, and there is single support, single support. Okay, so that is how running happens. Okay, so that is the difference between walking and running. Now what we will do is we have to go deep. This is just an introduction. Okay, so we need to know gait cycle. One was the stance, another was the swing. Within the stance, there is a 2 periods of double support, initial double support and terminal double support. So this is again in the timing. Okay, so total stance phase is 60% and total swing phase is 10%. Okay, and in the initial 10% and again one more 10% of double support is there. First double support and second double support. Before we just go into actual muscle action and what all happens during those things, we need to be clear about some concepts here. Okay, we know this, but then it helps to actually reiterate some points. When you talk about contraction of a muscle in this kind of during the gait, okay, there are concentric, eccentric, and isometric contractions. Okay, basically we talk about concentric contraction and eccentric contraction. So just imagine this person who is holding something. Here it is just a glass. Imagine that it is something very heavy. Now, when the glass is moving upwards, when he is actually flexing this biceps will actually be contracting and becoming shorter to make sure that the glass actually is pulled upwards. The glass goes upwards. Now, when the glass is being let down, going down, or if it is something heavy, it is being let down. At that time also, this is continuing to contract, but to allow a controlled release of the weight downwards, this will continue to contract but start lengthening. So when it is contracting or when it is acting, but it is shortening, it is called as concentric contraction. When it is acting, but it is lengthening, it is called as eccentric action or eccentric contraction. Of the word contraction in English, it may be not appropriate, but then it is used. So there is a concentric action when it is shortening, and then eccentric action. If it is just holding something in the mid-air, neither contraction nor extension, then it will be called isometric action. So these are the 3 things. Why we came to all these things? Simple examples, not fully into detail, but some example to understand the amount of synergies that need to happen for us to have a normal gait. I will do that. Okay. So when the first look at the extreme end, the heel strike. So what happened here is the heel came and struck the ground. So this is like a heavy body comes. If you actually, what will happen if you step onto our weighing whatever in the bathroom weighing machine that we have? When you step onto that, you will first notice that the initial reading is actually more than your actual weight. This happens because of the body actually suddenly decelerating when it makes a step onto something. So what happens is the pressure that amount of pressure that is exerted downwards will be more than the body weight. Okay, so what will happen? The entire body at that time tries to go down. One. So there are 2 things that will happen here. The entire body will try to go down. That has to be somehow absorbed. So what happens is when you see this knee goes into a partial flexion of around 15 degrees of flexion the knee reaches. But that flexion is a controlled flexion. Okay, that flexion is a controlled flexion which is acting against. So there is the quadriceps muscle here, which is actually an extensor of the knee joint. So it is an extensor of the knee joint which should make the knee joint straight. Whereas it will now work, if you remember this thing, it will now work eccentric contraction. So eccentric contraction means it is contracting but allowing itself to be stretched so that the body actually goes down a little. There is going to be some amount of flexion by about 50 degrees. So the shock is absorbed at that level. And one more thing that happens here is the foot, it is upwards. The front of the foot will be upwards when the heel strikes. So there is going to be a tendency for the foot to actually slap down. That has to be prevented. That prevention happens from the tibialis action, so that slapping down will not happen. It's a controlled slapping. So these two things are examples of eccentric action. So let us see here in the mid stance. Okay, here from here, when the body has to be pushed forward, here the body pushes forward. If you see here, the body is behind the foot. Here the body is straight above the foot. Here the body is just in front of the foot. What has happened here is from here to here, the body has been pushed forward. That pushing forward has been achieved by actually a hip extension. So the hip extension actually means the leg with respect to the body, the thigh with respect to the body, and the leg with respect to the body actually moves backwards. So that is exactly what was happened, which has been achieved by hip extensors, and the body moves forward. This one is a concentric action. So this one is a concentric action. But even during that concentric action, there are opposing muscles which continue. So this kind of actions keep happening. And so at every point of time. So I'll not go into the full details here. Okay. But then I'll just get into the muscles. Okay. Okay. Now that was just to explain what all will happen. So now so first one is loading, okay, to receiving the weight. Okay. So like that, there are multiple. Now we'll get into the details. Okay. So before that, types of muscle movement limitations. Okay. So much of things should happen based on the full range of muscle movement. But full range of muscle movement itself may not happen for a variety of reasons. So it can happen because of contractures. It can happen because of spasticity. It can happen because of rigidity. What is contracture? It is shortening or a reduction. If the muscle is shortened, it's a reduction in the passive range of motion of a joint. So passive range of motion. Okay, passively, if you move the joint, how much you can move, it is not possible because the muscle is actually shortened, permanently shortened, and it is the same. It is a static shortening. Spasticity is velocity dependent, resistant to stretch. So when you look at a person who is having spasticity, just because maybe because of a hemiplegia or whatever, if you try to slowly pull, it will come out. If you try to pull fast, the resistance to pulling is even more. So it is a velocity dependent resistance to stretch. When you talk about rigidity, as you see in some of these basal ganglia type of lesions and all those things, there is a resistance to stretch, but that is not velocity dependent. Okay, that is a constant resistance to stretch, and that is rigidity. So there is a contracture, which is a shortening, then there is a spasticity, and there is a rigidity. So we know all these things. Any of these things we know because when we saw the previous Gait cycle, it is all dependent on muscle actions. Any of these things of muscle movement, muscle problems can cause limitations in muscle movement. So if because of that, it will cause limitations in the joint movement. Because of that, it will cause limitations in the way in which the Gait cycle can be performed. Now, in the Gait cycle, when we saw things here. So what exactly? How do we discuss? So there is a swing here, there is a load expectance, and there is a body to be propelled forward. So what are the muscles? What are the actions? So loading or weight acceptance. So adequate knee flexion, the loading or weight acceptance is at this stage. So when the person actually puts the heel down and makes the foot flat. Okay. So during this time the weight is being accepted to this side of the foot. So what happens here is adequate knee flexion to absorb the shock by about 50 degrees. Here, what is happening? Eccentric contraction of the quadriceps. Good limb stability as the foot contacts the ground. So this is another prerequisite that should happen. So eccentric contraction of the tibialis anterior muscle. Okay. So the tibialis anterior muscle has to eccentrically contract here so that this does not just slap. If there is a palsy of that, you have something called foot drop. So that should not happen. Then concentric contraction of the quadriceps and eccentric contraction of the hip extensor. These two things make sure that this actually becomes. These two things make sure that okay, after the initial contraction, again it reaches a mid stance or complete weight acceptance stance where the thigh and the upper body is straight. Okay. Now, ability to keep the center of mass moving forward. So this is achieved. So center of mass keeps moving forward, eccentric contraction of the gastrocnemius soleus. That is this thing. So what will happen is this has to be a controlled movement. So this forward movement has to be a controlled movement. So here there is the gastrocnemius and soleus. So what this does is make sure that when the body is actually moving forward, that is controlled movement, and so this actually holds it back little so that it releases it controlled when the other things are actually pushing the forward. One is the inertia and another is the other muscles action is pushing it forward. This much is happening. Okay, so there are some muscles which are acting eccentrically, there are some muscles which are acting concentrically. Then is the single limb support. One limb accepts complete responsibility for supporting the total body weight, and it has to propel the trunk forward. The muscle groups activated are hip abductors, the trunk muscles to hold the body straight, plantar flexors, eccentric contraction to control the forward movement of the tibia, that is the gastrocnemius and soleus, okay, which actually are acting against it, but to make sure the body moves in a controlled fashion. And then the quadriceps to assist forward progression of the COG, again eccentric contraction, okay, which means it is actually trying to work like a speed breaker or whatever to control it. So that is what is happening when the body is being propelled forwards. Okay. Now the next thing is this everything within the 5 minutes. Why we went into so much detail will become apparent, because if you have to rehabilitate these people, what we need to be doing is what is going to come next. Next is the limb advancement. So what is limb advancement? When the limb, okay, toe off, and then the limb goes forward in the swing phase and then goes and does the heel strike. So what happens there is, in the pre-swing, in preparation of the foot being lifted off the floor, knee flexion by 35 degrees happens. So in preparation, the knee gets flexed by around 35 degrees here. In preparation, it is not yet lifted off. Okay. Next is swing phase limb advancement, continued knee flexion to about 60 degrees. It continues to the, then these, after that, the knee is propelled forwards, okay, by the action of the quadriceps. Now total clearance of the foot achieved is just 1 centimeter from the floor. That is all we achieve. We don't achieve much. So that is why when in a normal gait, only 1 centimeter. So little bit of problem with any of these muscles, okay, even a foot drop or whatever, there can be a problem in the foot clearing the floor. Okay. So this much is the action. So hamstrings, dorsiflexus, quadriceps, and iliopsoas. All these things work for this particular limb advancement phase. Now, so if somebody is having a gait problem because of muscle related issues, there can be a lot of this, any of these muscles can be affected. The next thing here is, so this was that. So which are the muscles we need to consider when we try to rehabilitate, to strengthen, if at all, because of a muscle strength issue or whatever it is? These are the things that will come. Okay. Now, when you come to a person who is having a cautious gait, an elderly person, the first change that happens in an elderly person is, I'll come to some metrics a little later, but in an elderly person, now what will happen here is, okay, this stance phase will be okay. The swing will be very small. The swing will be very small. He will not reach long. So the elderly person actually becomes slow, not because he takes less number of steps, but he takes a little bit smaller swing. When he takes a smaller swing, what will happen? The range of motion, because of his caution, the range of motion becomes small. Because the range of motion at the joints becomes small, the muscles also, as a result of his cautious gait, start becoming weak. So we need to strengthen for that. That is why we need to know exactly what are all the things. So hip joint movers in the sagittal plane. The flexor is the iliopsoas. This is from the front. So you are seeing it, it takes origin from this vertebral column as well as from the hip bone, and then gets attached to the femur. And then the gluteus, the extensors are the gluteus maximus, and of course the gluteus maximus, this is from the back you are seeing. So again it takes origin from the hip bone, okay, and then inserts into the femur. And then the hamstring, one hamstring is the biceps femoris. Okay, so biceps femoris, which goes all the way, it is trans joint, it doesn't, it goes beyond the knee joint and gets attached to the fibula. So these are the hip joint movers. So when you talk about rehabilitation, we need to be thinking about giving exercises to actually strengthen these particular muscles. Now, hip joint movers in the frontal plane means to prevent that waddling, okay, of action. So the gluteus medius is the one that will actually prevent the waddling of the gait. This is the abductor, and the adductor muscle is the adductor longus. The knee joint movers, the quadriceps, that is the rectus femoris, okay, which takes origin from the hip, from the it takes origin from the pelvis, and then it goes to the patella. Then we have the vastus lateralis, vastus medialis, and vastus intermedius. So all the four put together will be considered as the quadriceps. Okay, will be considered as the quadriceps. The flexor is again what we saw before. Okay, that is the biceps femoris, which is the hamstring. Okay. Now, ankle joint movers in the sagittal plane. The ankle joint movers are the gastrocnemius and soleus, which are on the posterior aspect, and the dorsiflexor is nothing but the tibialis anterior. So this will prevent a foot drop, and these two things will make sure that by their contraction, if they are contracting, the forward movement there is a dampening effect on the forward movement of the body. So there is a controlled forward movement. So that is why during eccentric contraction, the body it will make a control. Now, ankle and foot joint movers in the frontal plane, we have the peroneus longus and the tibialis anterior. So what the peroneus does is eversion, and tibialis anterior is the inversion. Inversion is where the foot, okay, sole will turn inwards. Eversion is when it turns outwards. So all these things are very, very important. These are the muscles which are very, very important for gait. So when we talk about gait rehabilitation, and if you are actually dealing with muscle strengthening, these muscles we have to give exercises to make sure that these are strong and these are working well, these are flexible, these have the full range. Now coming to the basic measurements. Okay, the basic measurements, we have the spatial parameters and the temporal parameters in the gait. Okay, so when it comes to spatial parameters, we have the step length and the stride length and the stride width. All these things will come in the diagrams when I explain. Okay, and the temporal parameters are the stride time, cadence, and walking speed. When we start reading about gait related abnormalities, all these things, we start getting all this terminology being thrown at us. So once we know them, then it becomes very easy to actually understand what they are trying to tell. So step length is, see, one heel to another heel. So from one heel of one foot to the heel of the another foot is the step length. The stride length is from one heel strike place to the next heel strike place of the same leg. So that is stride. So stride actually means one full gait cycle. Step is just half the gait cycle where only one step is taken. So this is stride. So the stride time is the time for the entire gait cycle. So step and stride length for symmetrical walking. When you talk about symmetrical walking, when a person is normal or whatever, or when the dysfunction is not causing asymmetrical walking, you start seeing step and stride lengths for symmetrical walking, where you can see this the step length when taking step with the right foot versus left foot are the same. Okay, so this is what happens there. Stride is the entire one from right foot to oppose again the right foot. In asymmetrical walking, as happens in a person with hemiplegia, one foot does not go beyond. Okay, so in that case, it only reaches up to a certain level. So in that case, what you start seeing is asymmetrical walking. Asymmetrical walking generally means that there is a unilateral deficit or asymmetric deficit. Now, stride width, there are different things that are taken for stride width. Okay, some workers take the heel to heel distance, and some other workers take the mid foot to mid foot distance. Based on that, it can be different. Now, these were all the parameters that we needed to know. Now we will get into a little bit about more pathology, classification, a little bit of clinical assessment, and then we will get into the rehabilitation. The 4 requisite attributes for normal gait are adequate range of joint mobility. So we saw the gait. In that gait, we saw how much of knee flexion is needed, how much of hip extension and hip flexion is needed, how much of ankle flexion is needed. All these things we saw. So that much of range of joint mobility is very, very important. Sufficient muscle strength to meet the demands in each phase of the gait cycle. Appropriate timing of muscle activation across the gait cycle. We saw, so when one muscle is working, another muscle also should be synergistically at the same time. That is very important. If one works when it should not be working, then there is going to be a problem. So unimpaired sensory input from visual, somatosensory and vestibular systems. Just to tell, in the beginning we saw anticipatory responses. Just one example of how anticipatory responses can be given by the visual system. Let us see. Okay. So for vision, proactive control of locomotion, you see avoidance strategy. So if you see something in already ahead, so what will happen? You can do either an avoidance strategy or accommodation strategy based on what you have seen, what the eyes have seen. Okay, momentary modification of gait cycle to avoid a barrier in the environment. So you see something, there is some, okay, there's a pothole, you try to sidestep and go. So that's a momentary modification of the gait cycle. Whereas an accommodation strategy is adaptation of gait cycle. Means this is more sustained environmental problem. So the gait cycle itself has to be adapted to a new strategy. Okay. So what happens is changing step length on a slippery surface. If the surface is slippery, you start taking smaller steps and increasing contractile power while climbing the stairs. So this is the accommodation strategy. That is adaptation. Avoidance is just a momentary change in gait cycle. So this thing. Okay. In people with central problems, there is a problem in even doing this kind of, okay, anticipatory strategies. Proactive controls is problem. So the levels of gait disorders, when we saw all these things, we saw the gait cycle, the muscles, the joints, the bones, all these things, nerves and all these things. When you talk about gait disorders, the gait disorders that trouble us the most is this something called high level gait disorder. These are the people who come to us, everything seems to be normal, but that person is suffering. Okay. So that one. So the lowest one are peripheral musculoskeletal problems, which is just, okay, which is almost intuitive. The moment you see, you can come to know. And then peripheral sensory, vision, proprioception or vestibular problem. All these things, if any of these peripheral sensory level problems or peripheral musculoskeletal problems, these things are considered as lowest level gait disorder. The mid-level gait disorder is where there is a disruption in the descending motor pathways, ascending sensory pathways. Classic. Okay, so example, this is considered as a mid-level problems. Okay, brainstem, spinal cord, cerebellum, whatever, including hemiplegia is considered as a middle-level problem because it is about descending motor pathway. The high-level ones are the problem on the cortical basal ganglia thalamocortical loop lesions. What exactly is this thalamocortical loop lesions? We'll come to that. When you talk about cortical basal ganglia thalamocortical loop, this was described. Okay. So this is from the cortex. It's a network which goes to the cortex, to the basal ganglia, to the thalami, and also to the pedunculopontine nucleus. So there is this full loop, okay, from the ventrolateral thalamus again back to the cortex. So this loop, what does this loop do? This is important for adaptive control of movement. Adaptive control of movement is when, okay, this is very, very important. Okay, adaptive control of movement is very important. One is for initiation of movements. Okay, the other one is for rescue responses. Okay, so it facilitates desired movements and postural synergies and suppress undesired movements and undesired postures. So all these things happens at this particular level. So a lot of problems that we see, okay, advanced Parkinsonism, Alzheimer's disease, okay, the disease because of what we consider as cerebral small vessel disease. All these things are this level problems. Okay, so the clinical features of highest level gait disorders are hesitation and freezing. This you know, okay? Hesitation and freezing. Hesitation is in the beginning of the gait cycle. When we saw in the beginning essentials of gait, okay, essentials of normal walking, we saw one was the equilibrium, another was the locomotion. In the locomotion, initiation, okay? So that initiation, if they are not able to do, that will lead to hesitation in starting the gait. Freezing also happens when they are suddenly trying to take a turn or whatever it is, suddenly they freeze, they cannot do anything. So this is one problem. Okay, absent or inappropriate rescue reactions. Okay, if you try to, if that person is pushed to one side or suddenly encounters a jerk or something, he cannot, or if he's walking and suddenly a dog comes or whatever, he cannot do the exact rescue reaction that is needed for him. Next thing is variable performance. At one point of time in a stable ground, he may be probably walking very well. You make a small change in the environment, put two obstacles, and then he struggles too much. Or based on his mood, at one point of time he can walk very nicely, another point of time he cannot walk very nicely. These are the features. Then the first line I come. Inappropriate posture or sometimes counterproductive postural synergies and interaction with the environment. Okay, sometimes even bizarre foot placement. Now, if leaning in the wrong direction while turning we need to lean, but this person actually does inappropriate strategies, inappropriate postural synergy, he leans in the wrong direction. When you from the sitting position or from the you need to stand up, okay, we put one foot a little forward and then stand up. So these people, what they do, they put it a little more forward. So intrusive leg crossing while turning, or while when you ask them to turn, the leg crossing, instead of actually facilitating, it will intrude and actually cross over on the other leg. So this kind of things can happen. So these are the clinical features of the highest level gait disorders, which have been manifest with multiple different names have been given and all those things, but they fall under these four categories of features. So in this highest level gait disorder, what we need to be looking for, which we have not been doing, what happens in them, the greatest difficulty that they face is making transitional locomotor movements from one steady state to another. Okay, so what is transitional? From standing, they have to start walking. That is difficult. From walking, they have to suddenly turn. That is difficult. Continuous walking, once they have started, they can do. Standing, once they have stood, they can do. But transition, this extends to such an extent that it is not just only when standing and walking, because this is at a higher level disorder, where even lying down, ask them to lie down, there is a hesitation. In the lying down position, ask them to roll over, there is an hesitation. So this kind of a problem is there in them, hesitation. The other clinical test in higher level gait disorder that we do is, especially in Parkinsonism, the pull test. In the pull test, again, this is a test. So this is what every time the beginning classification, the first slide is very important. The first slide where we talk about in the equilibrium rescue reaction. Okay, rescue reaction. If the rescue also fails, then we do how to take care when we fall also. Okay, but the rescue reaction is very important. Now, what happens in these people? The rescue reaction is not working. What is rescue reaction? We saw examples. One was the windmill. The other one was the stepping strategy and all this. So if you take a person with a higher level gait problem, stand behind him. Okay, give enough space, hold the shoulder and pull it very back. Pull it so hard that the only way he can avoid his fall is by actually taking a step backwards. If he takes a step backward, no problem. But higher level gait problem people will not be able to take that step backward, and they will actually not be able to avoid that fall, in which case we'll have to be ready to hold them. So basically what is happening in a lot of these people with gait disorders, we saw if it is a musculoskeletal problem, we rescue it. If it is a sensory problem, we change it. Cataract needed, cataract surgery. Proprioceptive problem, we try to correct that. Vestibular, yes, we'll give specific vestibular rehabilitation. If the joint mobility range is less, age appropriate increase in the joint range we need to do. We should not attempt too fast. It has to be slow. So there is a structured method to be followed. Okay, so that is rehabilitation. The best book for this is, there is something called Fall Proof. There is a book by name Fall Proof, which has beautiful set of exercises for a lot of these things. Okay, I highly recommend that particular book for anybody who is interested in taking care of people with gait related abnormalities. There are a lot of things. Now, what I'm now trying to give the rehabilitation examples now is more related to rescuing, these people, so that they have enough postural synergies, they have good postural synergies and enough of action, things that they can do in their bank, okay, enough choices in their kitty, okay, so that they can actually come when there is a problem, if when they are going, a dog comes, they can avoid without falling, these kind of things. So we have to increase that capacity by increasing the number of appropriate responses they are capable of. So how do you rehabilitate them? Okay, first one, that okay, you have to take them in a hierarchical, in a level, okay, level by one, level 1, 2, 3, 4. First, make them practice abrupt starts and stops. So you ask him to start walking and you tell him that I am going to start music or stop music. The moment music stops, you have to stop. Or I am going to tell you to stop at that particular point of time, you have to stop. When I ask you to start, you have to start. So this is the first thing that we can do. Just make them practice abrupt starts and stops. The next thing is make him practice direction changes. So in the initial direction is red. Now at your command, you tell right, he has to turn. So each and every time it can be quarter turn, half turn, full turn. So the moment you tell, see, I want you to turn right, he has to turn right. At another point of time, you tell above turn, he has to turn fully. Then you have to ask him to turn full turn. So he is going straight ahead. He has to make full turn and continue to go straight. So this is the next practice. The beginning practice was abrupt starts and abrupt starts. Next is direction change. Next is forward stepping, alternating. First he has to learn side stepping, then only forward stepping. Then he has to do, when you ask him to do forward steps, he has to take forward step. And when you ask him to take side steps, he has to take side steps. So like this. So he has to take forward steps, alternating with side stepping. So this practice he has to do. The next thing that you can give him, again, changing the walking pattern on command. You ask him, now you start doing side stepping. Now you start walking. Now you start doing high stepping. So when high stepping is where the knees are hyperflexed like that. So that kind of a action. So high steps, side steps, and so this is side to side movement. This is forward movement. So all the three, one after the other. So normal movement. Then you give him different path directional patterns. So you tell him first you have to walk in this zigzag path. So zigzag path. This is hierarchical from one level to another level. When we go to the last rehabilitation step, he will have enough in his kitty. So ask him to walk in a zigzag path. In the beginning, it was only on command, turn right, turn left. Now it is more of on his own, he keep doing, okay, on a zigzag path. Then you make him walk on a figure of 8. Okay, figure of 8 in one direction, then again in the figure of 8 in the opposite direction. Then you ask him to write big circles and walk around the circles. First big circle, next a little smaller circle. As he progresses and progresses, smaller and smaller circles, he should walk around them. First rightwards and the next leftwards. So clockwise and counterclockwise. This kind of practice that they need to do. Now, other thing is on the floor, you can write 2 lines or you can stick a plaster so that one is narrow and another is wide. So narrow is only 5 centimeters apart, and you ask him, he has to step only on that particular line. Okay. So at narrow step he has to do. After that, he has to alternate it with wide step. Then you can have a place where first he does narrow, then he shifts to wide, then he shifts to narrow, then he shifts to wide, like this. Next is something called a step 2 walking, which is very beautiful. So in step 2 walking, what he does is, so what you see here is one limb goes forward, the opposite limb, instead of advancing ahead, it only comes to this foot. So it reaches only reaches that foot. Each of these things will strengthen a different type of rescue mechanisms. This is step 2 walking. once you can have the right limb as the advancing limb, and the second time you can have the left limb as the advancing limb. Then you can progress to a level where they do toe walking. So they walk only on the tiptoes. Okay, and this may take a long time by the time they reach this, because we are talking about a person who had a higher level gait abnormality. To the time they reach this stage, there may be a lot of effort. Then make them do the heel walking. Okay, the heel walking. This is okay. So not all in one day, not all in one few days. Also, this progresses over weeks. Then braiding. So in braiding, what happens? Braiding back and braiding front, two things are there. What happens is you take the step forward. The next step actually comes and only touches up to the heel, like this. He goes, touches up to the heel. So that is braiding back. Okay, from the back it comes and reaches there and touches the heel. In braiding front, it crosses over and comes to the front. Okay, so advancing limb goes front, the trailing limb comes, crosses over and comes to the front. This is the braiding. Then you make them do the tandem walking. So in tandem walking is heel to toe walking. You make them do heel to toe walking. Then we give them something called obstacle avoidance. So we place these kind of conical things on the floor, and then you ask them to go walk, avoiding them and taking a zigzag path, avoiding them. Next is a obstacle negotiation. During the obstacle, they have to you tell them to actually step on that. And when you actually make them step on that, they will have to have different kinds of things. One of these seat can be solid, another one can be foam, another one can be between foam and solid like a rubber. So all these things, they can step on one after the other. By the time they have done, and then walking on a narrow plank, you make a very narrow plank on the height, and then you make them walk on a narrow plank. And each of these tasks can be made to become more difficult by actually asking them to hold something like a basket or something, so that they cannot actually look down. You can at each of these things, you can make it more complicated by keeping something on the head, so that the task becomes more difficult. All these things. So what will happen is the bank of rescue responses that they have will increase in this particular patients. So in the beginning, the lowest level, we have to make sure that the joint range of motion is good. We have to make sure that the muscle strength is good by the appropriate exercises. They have not dealt with the particular exercises for muscle strengthening and the joint range of motion. There are beautiful exercises in the book called Fall Proof. And then you can advance to a stage where you start giving more and more rescue responses to this, strengthening their bank of rescue responses that they are able to do, so that they become better walkers or more safer walkers. Thank you.
Sir, excellent presentation, sir.
Thank you, sir.
Amazing presentation, sir. Amazing, sir. Niranjan sir want to say something, I think.
Yeah, so I think before we proceed to question answers, I'll quickly run through next week's agenda. There is a slight change in timings next week. Yeah, so next week we are starting at 5:30 p.m. Indian Standard Time and not at 4:30 p.m. This is primarily to accommodate Dr. Lillian Philippi from USA. I think she's from New York, and there's a 9.5 hours time difference. So we have 4 sessions next week. First one by Dr. Vishal Pawar on approach to nystagmus, followed by Dr. Lillian Philippi on microgravity and balance. And then we have 2 case presentations, one by Dr. Neeraj Kumar from All India Institute of Speech and Hearing, Mysore, and the second one by Dr. Kshitij Malik from Delhi on presbyvestibulopathy, bilateral vestibular failure. So looking forward to seeing everyone next week as well. Please note again that the session starts from 5:30 p.m. next week. So over to Prateek for question and answers.
Thank you so much, sir. So we will take up the question answer. So we will start with Dr. Maja ma'am. Maja ma'am.
Yes, I think I have already answered many questions I have
Yes,
seen
ma'am.
in Q&A, so they are answered, I think, and I see there only for Dr. Srinivasa answers.
Yes, ma'am.
My are answered.
Yes, ma'am. Ma'am, but still we will ask you few questions because all the other audience also want to know the answers.
Mhm.
So, what is the pattern of nystagmus seen in vestibular migraine patients?
Yeah, in vestibular migraine, generally, we can find any pattern of nystagmus. We can find horizontal, pure horizontal, torsional horizontal, but we can find also vertical nystagmus, as migraine can mimic everything, I would say. Yeah, the migraine is also usually or often overlapping with Meniere's disease, and there is sometimes big mismatch when evaluating the patient with vestibular migraine. So I think I answered. So
Yes,
any
ma'am.
pattern of nystagmus, horizontal, vertical as well.
Yes, ma'am. Anything it can be. Yes. Ma'am, do you routinely use video head impulse test in acute settings?
Yes, I do it every time because I have video head impulse test. So that's the best way how to evaluate quickly the patient, because I have to say I love the video head impulse test because it shows me quickly the results, and I see all the saccades covered over it. I see the gain, so it's the best evaluation, I think, in the acute stage.
Yes,
Just to follow the nystagmus, then rehead, then skew standing, like in this protocol, and then autologic and neurologic evaluation as well.
yes, ma'am. Ma'am, do you test for all the 6 canals or just the horizontal canals, ma'am?
I do test all the 6 canals.
All the 6 canals.
Yeah, only in when it's problematic because of the pain of the neck. That's the only reason. Maybe in very old people who will not allow me to move with the neck in vertical canals. So also the vertical canals are not sufficient, or the result is not so sufficient. But in horizontal canal, always.
Yes, ma'am. Yes, ma'am. Ma'am, head impulse test can be impaired in central pathology also. So can you name few of them, ma'am?
Yes, we have talked about, especially in ICA strokes, it can be impaired, and also bilaterally can be impaired in some cerebral impairment, especially, and also vestibular nuclear impairment. So pontomedullary junction also can do the impairment of vestibular ocular reflex and also the HIT.
Yes, ma'am.
I think.
Yes, ma'am. Dr. Hitesh Patel wants to know that in vestibular migraine, what types of smooth pursuit and saccade do you see normally?
As well as in spontaneous nystagmus, many patterns of smooth pursuit can be present, especially saccadic eye smooth pursuit or jerky smooth pursuit. This is the same saccadic. Broken smooth pursuit, and in saccadic eye movements, especially delayed onset of the saccade.
Yes, ma'am. Dr. Aditya is asking about kindly describe Uttenberger test and the inference which we can get from Uttenberger test.
Yeah, I have described it to him that it's otolaryngology test to assess vestibular pathology. It's not so useful for detecting the central disorders of balance. The patient is asked to walk in the place with their eye closed for about 30 seconds, and we are looking for rotation of to one side, which we think it should be, which it could be with a labyrinthine lesion. But as we are evaluating this Unterberg's test in follow-ups, we can see that sometimes it's very useful in acute or subacute stage, but after how the compensation is coming, sometimes it's overcompensated. So sometimes on the follow-up, they can turn to contralateral side, contralesional side. So at the follow-ups, as time is going on, it's sometimes not so useful because it can cause the misleading result.
Yes, ma'am. Dr. Mayank is asking that when are you publishing this paper on 10-step protocol for acute vertigo?
We did not. It's also the question for Alfraga Muhammad, because I think we will try to improve it for the best way we can, and then we will think about some opportunities for this protocol.
Yes, ma'am. Ma'am, what was the diagnosis of the patient with bilateral positive head impulse test?
Yeah. First, I'm an ENT doctor, so first I thought it's some kind of stroke of cerebral or pontine stroke, but what was surprisingly, it was MRI negative. So the first MRI was negative, but it was sudden onset of slight instability, but for the most, it was the impossibility to of any gait, of any walking. She could not stand. And after that, on follow-ups, MRI, we have observed just hypertrophy of inferior olivary complex, and also on the follow-up after, I think, about 1 year, there was cerebral atrophy.
Okay, ma'am. Ma'am, what is the sensitivity and specificity of video head impulse test for acute vertigo?
From the literature, the sensitivity is very high. It's about 95% for detecting the vestibular deficit, but the specificity is not so high because you cannot always distinguish between central or peripheral vestibular lesions. So specificity is about 85% from the literature.
Yes, ma'am. Thank you so much, ma'am.
Thank you.
It was great to have you. Thank you so much, ma'am. Ma'am, now we have questions for Dr. Srinivasa. Dr. Manoj is asking Dr. Srinivas that can you tell about how to manage the patient of Parkinsonism and how to assess their gait-related problems?
No, actually, I think sir is not asking about management. Okay, management is beyond. Okay, so
Yes.
Sir is only asking about a few words about Parkinsonism and their gait-related problems. Okay, so again, this Parkinsonism in the beginning stage is considered as a mid-level gait problem, and later stage it will be considered as a high-level gait problem, where you are going to see a problem with the rescue reactions will not be there. Gait initiation will be a problem. Hesitation will be a problem. I mean, so gait initiation will be a problem. So there is going to be hesitation, and there is going to be one more thing is shuffling gait. So what will happen? Short shuffles means the foot seems to drag on the ground. So that kind of, and short steps rather than big steps. In the beginning, cadence will be increased. So cadence is the number of steps you take in a particular time. In the beginning, it will be increased, but later on the cadence will become less. So in the though the cadence is increased in the beginning, still it will be slow because the steps will be shorter. As the disease progresses, even the cadence will be small. Surprisingly, what will happen in Parkinsonism is seen is they do well with cues. So if you tell, you keep giving a sound, tan, tan, tan. Each and every time you hear a sound, you have to take a step forward. They will start doing better. The other beautiful thing about Parkinsonism is again the one is the other thing is, if you want to force them to take bigger steps, you can actually draw lines on the floor and you tell you according to this you go. Surprisingly, they start taking bigger steps according to that line. So they respond to cues, okay, for some reason. So this is about Parkinsonism.
Yes, sir. Dr. Maharan is asking.
Yeah, we
Same-
can summarize. In fact, we can provide a table of all gates. In fact, we have a beautiful presentation on gates. There are 2 presentations on gate on Cyclops Learning Lab. Huge videos. They are complete. One is by Dr. Surajit Burman. Okay, that is balance. I think I'll do one thing. We will make a playlist of for
Gait
Gait.
disorder.
And in the playlist, we will put the Dr. Surajit Burman's thing, and also Dr. Vishal Pawar's demonstration on Gait. So both of them we will put there so that it becomes easy. Both of them are on there, but we have to include them in the playlist. We will do that.
Yes, sir. So our YouTube channel is
So
Cyclops
Dr.
Learning
Mahan,
Lab.
I think that question is answered, so that it will be available on Cyclops Learning Lab, sir.
Yeah, yes, sir. And Dr. Anjana is asking about, do you always advise rehab exercises for Parkinsonism along with medication? Can you share?
Rehabilitation, we have to give. We have to give. Okay. If not anything, the feel good they feel is so much. Okay. I think even Aditya's question was there. Now I'm not seeing Aditya.
Let me check, sir.
Aditya had asked a question about peripheral neuropathy. Yeah. Okay. DM with peripheral neuropathy. Again, for the same peripheral neuropathy. In fact, we make, for those people, we do a lot of TheraBand type of exercises, and even the other exercises which are there for Gait rehabilitation. Okay, we can give them. Okay, and tandem walking, for some reason, a lot of people give for a diabetic peripheral neuropathy in the rehabilitation stage. And of course, the other thing is we can give them this footwear which will enhance the sensation.
Footwear will enhance the sensation, sir.
There are some kinds of footwear which will come with what is that? Which will come with a rim of projecting things. In the sense, they'll be like thing. So which will enhance the sensation.
Yes, sir. Yes, sir.
The neurologist whom I used to work used to do that.
Yes, sir. Sir, there is a question from last to last session, sir. Do you advise?
Dr. Manoj, it is called acupressure footwear.
Yes, sir. Acupressure footwear. Yes, sir. Sir, do you test all the patient wearing a shoe, or you want to test all the patient like without any shoes or without any slippers on? Because
first thing is you test without the shoes.
Without the shoes on, yes, sir.
Yeah.
And sir, I think there is a lot of research which we are going to do, or with the dance therapy also, because all the steps which you mentioned can be inserted into a dance step, or like some Zumba dance or tango dance.
Yeah.
Yes, sir.
Yeah. One more thing is dance. I think Lorna has suggested that dance therapy. One more, Leanova name is not seen. It's come from Leanova. Is there any test protocol to analyze gait and balance related to muscles, strategies? Yeah. In fact, there are multiple published protocols, task specific protocols that are out there. Today, within this 1 hour, I had to choose between concepts versus covering all the strategies. So what I did is I just chose only to cover the concept so that we can actually get all these different protocols. In any case, that they are available in the books.
Yes, sir.
I don't have a computerized dynamic posturography, so I don't have a stabilogram also. Most of our gait analysis is observational gait analysis.
Yes, sir. Yes, sir. I think we have answered all the questions, sir.
Yeah, and we are in time, 7 o'clock.
Yes, sir. Yes, sir. Thank you so much, sir.
Thank you, sir. Thank you so much. Thank you. Thanks everyone for attending. Okay, thanks everyone for attending. It's really a great privilege to see so many people at this hour. Thank you all.
So I will be sharing a link for feedback. So kindly fill the feedback form. Thank you so much. Thank you all. So see you next week.
Dr. Maja for our excellent presentation. It was wonderful. Okay.
Yes, sir.
So, and I'm seeing a lot of comments. Everybody is telling it's good. So it's an encouragement for us to continue to keep doing better. Thank you all. Thank you all for joining, and thank you all for the participation in the Q&A and also in the chat feature. Thanks all.